Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with a fully blocked right ear, and this earwax and also dead skin plugs, it's a combination of the two, extends all the way from the entrance of the ear to the eardrum. And the reason why we know this wax plug also contains a lot of dead skin keratin, because you can see it's got this glossy finish to it. Sometimes if patients use earwax softening drops prior to attending, you can also get this glossy effect, but you'll also see the excess drops oozing out on the side. So there's no excess drops here, it's just very glossy around the edge and the surface, so we know that's dead skin. Dead skin has that characteristic. So it's quite sticky, this lateral part. I think I've actually just put some drops in myself because it is sticky. The core of this plug though is quite firm and solid. So I'm just suctioning some of this oil, and we're just trying to separate this wax plug and skin plug from around the perimeter, around the edge of the canal wall. Eventually, I removed the majority of this with a St. Bart's ear hook, and I've actually used a metal one. No particular reason why, I've just got loads in stock, and I thought, why not use one? Normally in clinic, if you've been watching my videos, this St. Bart's ear hook, I use a carbon fibre. But here I'm using a metal one. The differences are the metal one's just a lot more expensive, and they're a lot firmer. They don't have much bend. So with the carbon fibre ones that I use, I sometimes prefer to use that because they do have a bit of give. So if you do make contact with the ear canal and you're retracting the instrument from the ear, it's going to be less uncomfortable for the patient with a carbon fibre ear hook as opposed to the metal one. But I've got a few of these in stock, and I've been using these mechanical instruments for a long time now, so I'm pretty confident in their use. However, when we perform our clear wax training, we always train using the carbon fibre micro instruments. And once the delegates gets more confident and used to the instrumentation, they are free to use the metal ones if they so wish. So I've just used the hook there. I resisted the urge to use a Jobson horn, and the reason for that is you can see it's quite sticky around the edge, and sometimes with the consistency of a plug like this, if you use a Jobson horn, it's almost like spreading butter on a slice of toast. So sort of extracting this outwards, you're compressing it more against the canal walls. So I've just gone back in with the ear hook, and I'm going inferiorly. So when we say inferiorly, we mean at the bottom, at the base, and I've glided it. I've turned the hook, in this instance, anti-clockwise. So I am based in the UK, so I know someone commented that it should have been counterclockwise, which is still a term used in the UK, but more common in the UK we use anti-clockwise. So we got a large segment out there. And what I'm trying to do here, it is a bit sticky at the base, so I'm just using the suction just to lift this up and away. And I'm just wriggling this plug out. So it's two humongous plugs. If you watch till the end, you'll see these plugs. They measured around just shy of 4 centimetres. And again, if it is pure wax, you wouldn't be able to house this much wax in one's ear, because the average ear canal length is around 2.6 centimetres. So that with dead skin though, it coils, so you can compress a lot more skin in the ear canal as you can compared to earwax. So we've cleared the ear canal. You can see the eardrum now. The patient's got a very translucent, almost transparent eardrum. You can see the hammer bone running down vertically in the middle, and just to the left of the hammer bone, if you look at the eardrum, you can see the incus, also known as the anvil bone. So that's the middle of the three bones. And bottom left, you may see this bony structure, and the bottom left is like a little arc. That arc is actually known as the round window niche. For any audiologist or medics watching. So I will briefly explain what the round window niche is. So when sounds hit the eardrum, we've got the hammer bone. So the vibrations are transmitted through the hammer bone that's attached to the eardrum. And then these vibrations are then transmitted through the anvil, which is also known as the incus, and then finally to the stapes, also known as the stirrup. The stirrup bone is connected to the cochlea, the organ of hearing. And when that stirrup bone moves, and it's attached to a part of the cochlea called the oval window. So that's where the stapes, or as I said, the stirrup bone is attached to. And as that stirrup bone or stapes bone vibrates backwards and forwards, when it's attached to the oval window, it causes fluid in the organ of hearing to travel in waves depending upon the frequency. So the lower the frequency sound, these waves, these tidal waves, if you like, of fluid that's contained within the organ of hearing, you get them travelling throughout the organ of hearing. And the organ of hearing is like a snail. It coils upwards. Now, obviously, you've got all this fluid in the organ of hearing, and as the fluid's moving backwards and forwards, at the very end of the organ of hearing, so probably the best way to describe it, there's a little, almost like a pressure valve. So the fluid can move, but it won't escape the organ of hearing. It's like a little separate membrane, it's flexible. It moves outwards as the fluid moves backwards and forwards, but it contains all that fluid. If that fluid ever ruptures out of the organ of hearing, you'll lose all your hearing. So it's vital that this fluid doesn't escape. But obviously you've got these waves of fluid going backwards and forwards, and at the end of the organ of hearing, as I said, it's another membrane, and that's called the round window. And you can actually see the round window bottom left of screen through the eardrum. That's the round window niche. So what I was doing there, this patient's got another layer of dead skin that's coating the ear canal, and I'm just with the fine end suction gauge, just trying to remove as much as I can. It's never possible to remove all of it, but I did remove a fair piece there. Got to be careful as well, because you can get a bit of some blistering. You can see on the right hand side when we peel the skin, it's got a bit of blistering there. But I'm just going back to the top. There's a bit of a tail of skin here that I can grasp onto with the suction probe. Now, this patient will need their ears cleaned regularly. They've got a very irregular ear canal. There's loads of little bumps and troughs there. It's quite a bumpy ear canal. And that can sometimes stop the migration of skin. The skin gets trapped in these little bumps and cravets. I don't think I remove any more skin. The skin that's coating the more medial part, the inner part of the ear canal, is really strongly adhered. They're the chunks of dead skin and wax. You can see at the core, it's really dark, it's oxidized. I've just got a pencil tip there as comparison. I actually weighed this, and this is all from one ear, remember. So it's 565 grams, 0.565 grams, should I say. So more than half a gram. And side by side, it almost extends up to 4 centimetres. So the average ear canal length, as I mentioned previously, is about 2.6 centimetres. If that was purely wax, the wax has a firmer consistency. Of course, you can get compressed wax, but it's very unlikely you're going to get that amount of wax in one's ear. Instead, with skin, it can coil, so like ribbons. And that's where you can compact a lot more dead skin in the ear than you can earwax. Well, I hope you enjoyed that video, guys. When you're all having an enjoyable Good Friday, take care, keep well. Remember, be nice and be kind. Thank you. Bye.